technology industry has changed so dramatically. We are finally, because people have been working in trying to help the aging population for a long time with technology, having difficult times figuring this field out. We're finally seeing some unbelievable traction in helping seniors and their caregivers spot the important signs before they turn into serious problems. Enter predictive analytics. This next session is focused on just this. I'd like to welcome our next speakers to the stage. I love that they're just, having a good old social time. Come on up. To the stage and reintroduce to you to a moderator that we had up here earlier. Eric Taub is a writer for the New York Times and writes about the intersection of technology and society. So let's give him a round of applause to kick this off.
Hello again, everyone. I'm Eric Taub, as Jill just mentioned. So I'm back. You have me to kick around again. And if any of you are not aware of the news, the power has been out at the convention center for several hours, but from what I understand, according to a text, it's now back on. So if you go back there, you'll be able to navigate around the hall. So we're going to be talking about, as you know, predictive analytics. And we have a very interesting panel with us today. And right now, I'd like to introduce at first Brian Adams, who is the Chief Commercial Officer for Great Call. And Great Call has both a commercial and a consumer division. And you may know about the consumer division having established themselves as the premier product of cell phones for older people. But we're going to talk more about some of your commercial work, specifically around sensors for the elderly. And why don't you explain what you're doing in your Lively division?
Yeah, sure. Thank you. And thank you again for having us here on the panel today. Yep. Great Call's Lively home product, which we're going to talk a little bit about today in the context of predictive analytics, is a series of sensors that you put in the home of a senior who's looking to extend their independence. It's motion sensors in the bedroom, bathroom, front entry, living area, a contact sensor on the front door, refrigerator and cabinet, sensor that goes in the bed and detects in and out of bed, sensor that goes in the toilet tank, detects toilet flushes. We take all that data back, analyze it with our algorithms that we've been working on for years, and that generates essentially a risk estimate for that senior that says, is this person's behavior changing, and is it changing in a way that indicates that something might be up? And if you look down that list of folks, you should be able to find people who, if you reach out to them, and if you have a sort of case management, care management model, you're going to be able to substitute low-cost interventions, PCP visits, med reconciliations, for higher-cost emergency room visits or ultimately a loss of independence.
So what happens when you find out particular information around this sensor information? What do you do?
We have a team of folks in our caring center who look at our dashboard on a daily basis, and when they see someone's activity has changed, they make a call to that senior, that call is actually an incredibly important part. One question we sometimes get is, gosh, is that intrusive to the privacy of the senior? And what we found is that the sensors themselves aren't terribly intrusive. Home security systems have similar components. But if you make that call and you say, hey, you flushed your toilet 37 times yesterday, what's up? Then it feels very intrusive.
Flushing the grass down my toilet.
That's right.
The police come.
That's right. That would be a perfectly rational thing to say. Whereas if you treat it more like a wellness call and you say, hey, how are you feeling today? Has anything changed in your routine? You know that there's a change in toileting behavior, so you can direct the questions. The senior goes from feeling spied on and feeling like it's intrusive, and they go to feeling like, hey, this is someone who's got their eye on me and trying to take better care. So that's a part of the service that we provide, so that ultimately when that case manager who's managing that senior gets a note, they're sure that this is something that they should look into.
So who is this call center person? Where is your call center? How do you train these people to be appropriate?
Well, the Great Call has 2 caring centers that have a total of something around 800 folks who are providing all kinds of customer service and technical support, and we put our entire groups through senior sensitivity training. So
are they in this country, by the way?
They are, yes, in Carlsbad and in Reno. And they wear the glasses and the gloves and the ear protection so that they can really understand when you're talking to a senior, you have to talk at about a third of the velocity that I'm talking right now. You have to be a lot clearer, and you can ask people to confirm things. And we just feel like that segment of the offering where you have a human being who knows how to interact with the senior, really important part of the process.
And you said some people would find this intrusive. I know when I mentioned this sort of product to my mother-in-law, she said that would be the last thing I would want, regardless of whether I was the one calling her or a call center. So I'm sure you get some segment of the population that wouldn't touch this kind of product.
Yeah, what I would say is that it's most effective among seniors who are frail and at some risk for losing their independence. And I think as seniors get to that point where, gosh, is my ability to stay at home about to be compromised? The trade-off of, how about some sensors? We're not gonna, and there's no camera or microphone. We're not gonna, we have a bunch of language in say, we don't know how many people are in your bed. We don't know what's going on in the toilet. We're not here to be weird, but it's like a smoke detector. You would never live in a house without a smoke detector. And even if you don't think you're gonna need it, you still probably want one. So that's a little bit how we think about it. It's a smoke detector for those kinds of changes in behavior.
So how quickly will you notify somebody, and would you notify an adult caregiver if you saw somebody walking out the back door at 3 o'clock in the morning 12 times or something?
Yeah, that's right. That's right. We typically run data once a day and then make those calls. And usually the kinds of changes in activity that we find, a follow-up in 24 to 48 hours is usually enough to get that person the care they need before they end up in the emergency
Really?
room.
Because I would have thought if there's some kind of activity of people suddenly wandering, that could be really dangerous. Once a day wouldn't be enough.
Sure. For someone who's at risk for elopement, a different care level is usually needed. Though we do provide our Lively mobile device, which is a PERS device, so that if a senior feels that they're worried, they can press that button anytime and get help.
Okay. Pat, Karen, you're the Vice President of Innovation and R&D for United Healthcare.
Yes.
And you work with Brian and his company, don't you?
Absolutely, and actually we work with a lot of companies as well here too, to put that in perspective. But yes, we definitely work with Great Call in that senior space. So for United Healthcare, we service somewhere around 20 million in that senior space. So what we call our Medicare and retirement division of the company. So really focusing on that Medicare AARP group within United Health. And what we try to do is exactly what Brian was talking about here. It's how do we engage using technology as the enabler with these individuals? If it's through caregiving, through maybe myself caring for my parents, if it's through some of our licensed clinicians and the engagement that we have through them, what we do is we look for a lot of devices in the whole IoT space, and we look to aggregate then the data associated with that, where our clinicians, very similar to Great Call then, can engage then with our members appropriately. So if we're finding issues with an individual who's a type 2 diabetic, as an example, who is not taking their blood sugar readings on a regular basis, we don't see that information coming in. That allows us then to engage with them to say, what's going on? So it's very similar in how we approach that. And as we do that, we look for partners all over the spectrum and how we can utilize those devices, because everyone wants to use a device a little differently, and it may apply to a certain audience. So we have to have a whole portfolio of devices and programs that people could choose from them.
So tell us some of the other devices and programs and partners you have.
Yeah, absolutely. And we run the spectrum when it comes to engagement. So it could be as simple as we have a program called House Calls, where we actually have a nurse practitioner that will go into the home of our Medicare Advantage members once a year to do a physical exam, head-to-toe physical exam. But they will also, because they're in the home of the individual, will actually look for the tripping hazards, the medications that might be sitting on the countertop, looking for kind of the social aspects of how they are in their own living environment then. So it's not just about the healthcare, it's about the home healthcare environment and how they're engaging and how they're living within it. So today we will do 1.3 million of these visits nationwide. That is a platform. but then also we bring some augmentation to it using these devices, the type 2 diabetes device, maybe again working with Great Call and some of their products and services as well of how we bring that in.
Are you also working with products that monitor vital signs and so on?
We do, so the biometric readings, and there's a variety of them as well. Some of the newer ones are just simple tracking mechanisms of, are my parents going outside of the home at 3 in the morning? That's a potential trigger as well. It's something new like that, using things like Bluetooth technologies and RFID and all of that. But then also, can we use things like voice technologies, things like Google Home or Amazon Echo, where we can use that as a reminder for mom and dad that if I'm their caregiver, can I use Amazon Echo then as a medication reminder to say, Mom, remember, take your medication 8 a.m. this morning, and if mom doesn't respond using that voice mechanism, I as a caregiver get an alert. So there's many ways that we try to engage using these technologies that are simple to use, easy to engage with, and personalized.
So can you use voice technology, and are you doing so?
It's still early, but yes, we are actively working on 2 pilots today utilizing that in that senior space.
And those are pilots where? What sort of places?
Actually, so it's on what we call more on the wellness side of it. So it's in Denver and Chicago is the other one here. I don't remember that one. But it's all about the voice technology and having it into the home. So as Brian mentioned, it's working with, actually we work with a group called Best Buy, which I'm sure many of you may know about, where they install sensors into the home, very similar to what Brian was talking about here, your security sensors, water sensors, and whatnot, and that's all centralized in using a Amazon Echo device. But we also have embedded some healthcare engagement skills, what's called on the Amazon Echo. So if the individual needs a wellness coach, they would use the Echo to engage with the wellness coach that would be then utilized by our coaches then that would engage with them.
Okay, great. Stephanie, you've most recently been a consumer innovation executive for Humana. And when you were with Humana, what sort of work were you doing? Were you working with Great Call as well? And what are the innovations you were investigating?
Yeah, well, there's a few sides of it, and then I want to touch a little bit on the consumer piece, because I thought some of the questions you were asking earlier are pretty pivotal to how this space is going to emerge. But we actually engaged with Great Call in some conversations because we had been doing the biometric. And what's interesting is we spent 2 years first doing extreme ethnographic research, because it's one thing to develop and design for a population that you kind of live yourself. You know, I used to be in banking, and it was easy to know what the deposit product or the debit card needs to do, right? Because I lived it. It's quite another thing when you're working in a population that you don't live every day. And it's hard to blanket them 65 and 90. It's a very different dynamic within those 2 populations. And we found that there is a posture, there is a care recipient that feels very independent. They might have an entire network of caregivers, a live-in, somebody who takes them to the doctor, somebody who orders their medications, but they will tell you nobody cares for them and they don't have a caregiver. And they absolutely do not want anybody to say they are. But then you also have on the other end of the spectrum somebody who's very entitled. And either it's because of socioeconomic factors or where they've been in health their entire life, where they actually feel like the more health care gives me, it should be. And they basically should be paying for everything and keeping me well, and I'll take whatever they have to give. And in between, you have this kind of dependent, which I think from a Great Call perspective is a really interesting space, because they're recognizing that they're losing that independence slowly over time due to disabilities that emerge, and they start to become scared or depressed or go through all of these different feelings. And actually welcome, if there's a way that I can kind of still feel like I have my independence, but yet I'm living assisted at home instead of going to assisted living. So we started talking to them, because the biometrics, what happened to us is they started to name their devices because they were connected to Jill. And they recognized that this isn't just a scale or blood pressure cuff, but this is like Jill's watching, and now I know that somebody at least is looking out for my best interest and my health. The problem is engagement, right? Because we talk about 60 and 90, and your mom, I don't know that I want to deal with any of that. So passive is incredibly interesting in the space of both the caregiver being able to keep an eye on what's happening outside of the doctor's office and during the day, and whether or not they're functionally actually capable of doing their daily activities and patterns, but in a way that they don't have to actively engage in. It's happening for them. And when something kind of goes bump in the night, it's a brilliant trigger for being able to say, hey, you know what? This person's probably progressing a little bit. And so whether that's their informal caregiver, a daughter, a son, a husband, a wife, or whether that's a formal caregiver that's paid or a doctor, getting that message out there that just says, hey, something's changing here. You probably need to get another assessment or really maybe do some more testing on this person.
And did you find that there was pushback in terms of the creepiness factor?
You know, it's wild because if you watch seniors' behavior, the creepiness factor when you tell them about something, and especially if it sounds like an electronic or a technology, whoa, that's too much for me. But when you actually introduce it, it's very much so teach them to fish. When you introduce it and it comes with the value, I have not personally seen creepy. It's more of, am I going to mess that thing up? Am I going to do something wrong? Am I going to break it? Am I going to, like, it scares me, and I just don't know what to do because these are new fandangled devices.
So obviously, it sounds like you have to talk about the benefits of what you're going to be introducing as opposed to saying, we're going to put sensors in your toilet.
And that it's connected to care.
Right.
I think that when you do that, it changes the conversation and they get a little bit more comfortable.
And now, did you find any change in outcomes once you started doing this?
So we actually did not yet start with Great Call while I was at Humana. However, we were seeing positive outcomes from our other biometric devices, early stages, but we were seeing it more from the aspect of being able to reach people when something was triggered. So there was, and I'll tell you, the life-saving benefit, we would find that, we'd call somebody and say, hey, you were good, engaged, you were active, you were using your scale, all of a sudden it dropped off.
Right.
You call them, they answer the phone, they're short of breath, they're weak, and before you know it, you're sending EMS and you saved a life. And so that beneficial factor, and the more stories you tell like that, yes, you'll pick up on the disease progression, an acute event about to happen, but if you can also start to save lives and the family around this person, the community around this person start to get wind of that, it's very powerful.
Yeah, and I would imagine it's also powerful for the family to know that there's some technology that's looking out after their loved one. Brian, with the same kind of question I ask of you, what sort of proof do you have that your engagement does anything? Yeah, positive, I should say.
We, at Great Call, we have a study that was published in April of last year, the Journal of American Geriatric Society, which I'm sure everyone here has already read, we have brought here on the plane, that showed that we did a pilot with our partners in Massachusetts and looked at a population of folks who had the sensors and saw a pretty significant reduction, a 16% reduction in the total cost of care. And that when we broke it down by service line, saw mild increases in home care, pharmacy, and outpatient. Those were the result of some of those early interventions, and big reductions in long-term care, acute hospitalization, and skilled nursing. And when you think about that data on the aggregate, but you want to break it down to what actually happened, there were certainly lots of examples where you might have seen a toileting change, and you call and you find out that there might have been a med change, or there might have been a functional status change, or it could be any one of a number of things, or even the social determinants of health among the senior population can be a big part of it. We had a winter in Boston where we had 108 inches of snow and saw a reduction in access to the refrigerator and the cabinet. And what had happened is there was no one to shovel out the 108 inches of snow. Meals on Wheels couldn't get to the door, and this is a generation that I think you guys, but we've talked about this previously. They're not necessarily going to raise their hands to say, "Hey, I'm having trouble getting food." They're going to just try to make it last, and yet that failing to get food can be something that can lead to a loss of independence. And so, when you go back to this question of like, well, how does this fit into the senior's life? One of the stories we've said is this is going to help the caregivers you have provide you with better care. And I think that resonates positively with them.
So I think, a question for all of you. I mean, you just mentioned the weather. I mean, beyond just the obvious things of doing monitoring within a home, there are lots of other things you could monitor, and you could collate as well, right, to give you much better predictive analytics. What are some of those things that you've been looking at? You're looking at correlating weather? And
if we ever get another 108 inches of snow, I think we'll definitely factor that into the algorithms. No, I would say that one of the great parts of being in CES is that there are lots of folks out there who are working on new sensing modalities and interactive stuff, and we mentioned Amazon. And I think those are all a part of the puzzle. And I think that when we get to the point where this is something that is in our homes, there'll be wonderful technology to do this stuff. I think one thing that we've all really resonated on is the importance of that data, making it to a caregiver who knows how to take an action and be in that that context of just more raw data isn't going to solve the problem. It's got to be part of an overall solution that leads to the senior getting the care that they need. And so, certainly Alexa's a great example. Biometrics a great example.
Changes in social behavior. So they are engaging with family members, sometimes on Facebook, right? We've looked at do you want to start pulling in some of the third-party data? Is there anything that can give you any indication that they're becoming more socially isolated, right? That might be that they're not leaving their house, but it also might be that they've gotten very quiet on connecting, right? What about phone calls? Like, what are those other things that you can start to think about? Alexa, we did a test with Alexa with dementia, and it was more to see, can you start to replace some of the social isolation characteristics? Pretty much everybody that we tested played Frank Sinatra, which was pretty interesting. But listening to how they engaged with Alexa also started to tell you how they think about those types of voice-activated tools. One very odd thing is the name Alexa was hard for them. And the ability to remember who, how, and when to engage it. And so if we can start to use, the more tests like that you do, you start to create a conversational pattern that works with a population like that, but you can pick up so much, because if it becomes conversational, in the elderly population, they love to talk and share and give you information. And if you can pick out those relevant pieces and pick it up so easily in something like voice recognition, it'd be great.
Mm-hmm. Pat, have you done any work like that?
Oh, absolutely. And I think the bigger thing is that data is going to be king when it comes to all of this as well. So regardless of what devices that you use, how you're monitoring it, it's how you pull that data together and then start analyzing that data, looking for kind of the longer term trends associated with it, but also kind of the short term trends. Is mom and dad having a problem right now because they're not active today? But also, can we start looking at things such as gait? So individuals that maybe have a certain gait, but as they're having certain troubles, maybe with hips, maybe with other conditions that are going on, their gait may be shortened then by some of that conditions. If we start monitoring that, that gives us some analysis then and saying there might be some issues here that we are not quite sure what it could be, but let's get in front of it more from a preventative standpoint, maybe from a predictive standpoint. Instead of waiting us to be, we're such a reactionary environment today in the healthcare space, how can we get more front end on this? And I think that's what the data pieces are going to lend to it through a lot of that, what we're doing in the monitoring space, through whatever IoT devices out there, if it's voice, if it's video, if it's a gadget. If we pull that data together, I think we can be a lot more effective and efficient then in engaging early set, rather than waiting for that long-term issue.
So what do we need to get all this going? Because you're talking in the future.
Yeah, well, first of all, we need access to the data. And I think that's the bigger issue today. From a whole medical society standpoint today, everyone loves playing in their own sandbox. How do we get to the point of sharing that data? How do we have electronic medical records being shared across systems today? More on a US standpoint there. How do we open up some of our de-identified data to, again, start looking at high-level trends and doing analysis around that? So I think data sharing is first and foremost, but even with the data and that we have, how do we effectively analyze that today? How do we start using artificial intelligence, deep learning, those type of things that are starting to evolve right now into being a lot more effective than where we're at today? So I think it's a lot of trial and error. It's a lot of mathematics associated with finding the right algorithms and everything else to determine what are the right actionable points. I think we're getting there, but I think we're still on the cutting edge from a healthcare standpoint.
I think about this a lot because we actually worked on some integration with EMR platforms and trying to bring connected health data into it. But we really need to start to think about the caregiver and how, until we can get all the data integrated and the interoperability that we want and everything, there are people in the lives of every patient you serve already there. It's either because a post-discharge nurse or it's a family caregiver, or whoever it is, and make sure that the data can somehow get to them and they can be the quarterback. And you may not be able to get it all into one beautiful care plan yet. I think we would all love that and love to see a day when that can happen. So whoever's developing the major care plan, get on it. But I think we have to be able to trust and put data with people and make sure that you do it in a way that can be scalable and gives them just enough information that they need. And I actually believe it's there. I just don't think we're getting it to the right people. The communication between is what's not happening.
Well, but also you've got to filter that data as well. You can't just give people
Agreed.
tons of unusable
Agreed.
data. They don't even know which end to look at.
Insights probably more
Right.
than data.
Right.
Right.
And I think the great thing that you had brought up here, Stephanie, is that it's getting into the hands of the people, and I think there's multiple different pieces of the puzzle there when it comes to that. So it's the caregiver that can help take the action. It's the individual that needs access to the information. But I think it's also the provider. That provider needs to be a core aspect of this as well. We cannot cut out that relationship or the data analysis with that provider because they're really the trusted resource, essentially, other than the caregiver with that individual as well.
Yeah. What sort of headway, Brian, do you think you're making in terms of analyzing the data? You spoke about your algorithms.
Yeah. Well, you know what? I think that I would agree with all the things that you guys said at a even more sort of tactical level. You know, one of the big challenges of fielding a system like this is that you generate a ton of noise. You know,
Right.
and not just noise in terms of, any sensor by its very nature is going to generate noise. And we've spent a tremendous amount of time and effort to attenuate that noise, identify that noise, differentiate that noise from circumstances where there's an actual change in the world. But I would add that I think something that Stephanie said and something that we take pretty seriously at Great Call is that, and that Pat was saying, is that the ecosystem of care, it's a case manager, it's a family member, it's a provider, and so I think the end result of your analytics, they can and likely need to be pretty sophisticated, but it still has to be something that's meaningful to a caregiver. It has to be something that someone can take and say, I know what to do next to change the trajectory that a senior's on if they're on a trajectory of losing independence. So, I think those are the two things. And something you said earlier about product development. One of the real challenges is that this is a market where the seniors that you're working with are, particularly dually eligible seniors. They're not well represented in society. They're not out at the mall shopping. They're not, typically consumers. And so, we make it a point to send our developers into the homes of some of the folks that we're working with so that they can really understand the lives that these seniors are living so that the development that we're doing is appropriate for the setting that they live in.
Mm-hmm. So what sort of things are your developers learning when they go in the homes?
You go into the dwelling of a dually eligible senior and it's not the size that you thought it was, or the construction of the building that informs what kind of radios that you're going to use, or when it makes sense to, this seems like a silly example, but what's the environment of the bed? Is it a hospital bed? Is it a standard bed? What kind of mattress is it? And I think that one thing that people can sometimes do is say, well, this is a little bit like my parents, and to Stephanie's point, it's not necessary. You can't use yourself as the model. You can't necessarily use your parents as the model. So, it's challenging, but I think it's incredibly rewarding, and when you see the impact you can make on a senior's life, this has been one of the easiest things to recruit computer science people for because it's a hard technical problem, but you also feel like the result does a lot of societal good.
Is the actual market the caregiver as opposed to the person who requires the care, as we see so often in other products for the elderly?
I think that you have to satisfy multiple stakeholders,
Yeah.
but I think, Pat, you can say you guys are certainly one of the customers.
Yeah, no, and I would absolutely agree with that. It is both sides. It is the caregiver and there is the individual as well. And you're going to treat one differently. So the individual, as you were saying, is going to be more on the care of the individual. How do we use the enabling technology and make it easy for them to use? It's the caregiver that might be that deciding factor, that individual that's going to be working with mom or dad. How do we get them tooled up to be that right resource then for them?
Right.
And, yeah, it's two different environments though.
Yeah. I'm sorry, were you going to jump in?
You know, what my head clicked to is oddly, it's kind of the home too.
Yeah.
You know, it's how do you turn the place that's supposed to be safe and secure, how do you make sure that safety and security lasts through our aging years?
Yeah.
And so when you were talking about the mattress in the house, and we do safety checks and make sure that the stairs, that we're going up to the front door, if you want them to be able to get out and walk, you don't want them going down a long flight of stairs. And housing actually over the years hasn't stayed in the same lane as the fact that everybody's getting older, and these houses were built, and most masters are upstairs, and so for me, when I think about the power of things like sensors, it really is trying to think about how do you make the home something that we can fortify.
Yeah, and you certainly don't want a situation where some place that was seen as a bastion of safety becomes kind of like a horror show for
Right.
you as you get older.
Right.
I always think about when we talk about caregivers versus those who need care, that one of the early episodes of The Sopranos, when Tony was taking his mother to the assisted living home and they're showing her all the great features, and she says, I don't care about this. And he says, Mom, look at this, Mom, look at that. She says, I don't care about it. And he's the one who puts her in there. Yeah. Okay. There was another question I had that suddenly lost my train of thought. Oh, we actually were out of time. That was quick.
I wasn't going to rip you off stage, but.
Okay. Well, thank you, everybody, and
Yeah.
thanks for a great panel.
Great, thank you.